So we're going to look at M mode this morning. We're going to look at normal structure. So anything you do in echo, you have to know what's normal before you can make an assessment of abnormality. So we're going to look at after we look at normal structures, we're going to look at some pathology. We're going to look at what aortic stenosis looks like. We're going to look and see what bicuspid aortic valve looks like. Aortic regurgitation, mitral stenosis, uh, hypertrophic obstructive cardiomyopathy, left atrial myxoma, systolic heart failure, pulmonary hypertension, pulmonary stenosis, and cardiac tamponade. They you're going to get a lot of those of you who are going to do your echo exams. Even though we don't do a lot of M mode, you're going to get a lot of uh, questions related to M mode because, for one, it's an historical, it's very historical, and the pathologies are very distinct. So, what I would do is about probably 12, 14 conditions that they can bring you in M mode. So, I would know those conditions inside out, and these are some of them. Okay, aortic stenosis, know what that looks like in your M mode, bicuspid aortic valve, aortic regurgitation, mitral stenosis, hypertrophic obstructive cardiomyopathy, left atrial myxoma, systolic heart failure, pulmonary hypertension, pulmonary stenosis, and tamponade. So know what these different conditions look like on M mode because these things appear in all tests. So our M mode echo is really your time motion mode. We talk about two-dimensional, three-dimensional. Your M mode is just your time motion mode. And it was described as an ice pick view of the heart. And it gets its name from one of the original uh, individuals who did work in echo. It's put one patient deceased, you put an ice pick in a certain portion of the heart, and then you know they'll get an echo before the patient succumb. Put an ice pick in in the heart, and then see how it relates to what the echo shows. Um, on the vertical axis is distance, and then the horizontal axis is time, and I'll show you how that works. So you can get displacement by just looking at the vertical axis, and then on the horizontal axis you can get time. So if you remember, we use M mode to look at TAPSE because we want displacement, we want distance travel. So again, everything you do in echo is gated. So you're going to have your ECG, and it's going to be systole or diastole. So this appears in all exams. M mode has superior temporal resolution as compared to two-dimensional echo. Superior temporal resolution. Um, when we do ultrasound physics, then we'll go over what resolutions, what is resolution, and you have spatial resolution and temporal resolution, and we'll go over the difference between those two resolution. Okay, so when you look at your so when you look at your M mode, so on top we have our two-dimensional. This is your two-dimensional echo on top, and this is your M mode echo at the bottom. This cursor right here tells you the structures that you're looking at. And of course, this symbol represents your transducer. So your transducer is right up here, and the cursor right here, look at the structures that you're viewing. So on top, you're going to have the chest wall. And remember, the chest wall, you're going to have skin, subcutaneous tissue, you'll have muscles and stuff like that. So the first layer on top is the chest wall. Below the chest wall, you're going to have your pericardium. Below the pericardium, you're going to have your right ventricular wall, or the right ventricular wall, okay? Then you have your right ventricular cavity right there. Because those are the structures that looking at the heart, those are the structures in order that the cursor is looking at, that your transducer is looking at. Then from the right ventricular wall, you have your septum. This is your ventricular septum. Below the ventricular septum, you have the left ventricular cavity. Below the left ventricular cavity, you have the posterior wall and the pericardium. So this is your M mode at the mid-ventricular level. Transducer, of course, is on the chest. This is the symbol for the transducer. And then your cursor is right here, and these are the structures in succession. You see a two-dimensional echo is on top. Below, you have the M mode. So again, on the vertical axis, this is distance, and on the horizontal axis, you have time. Okay, so this is in millimeters. Okay, so each of these, it says 20 millimeters, 1, 2, 3, 4, 5, 6, 7, 8. So this is 160 millimeter. So each of these separation is 20 millimeters. So distance on the vertical axis, on the horizontal axis is time, and you can depends on the frame rate, you can work out the time intervals. So again, the first structure here, which is the first structure that your transducer is looking at, this is the chest wall. So this is the chest wall right here. Below the chest wall, look right there, below the chest wall, you have the pericardium. So the pericardium is going to be first, then the RV wall. So you have the pericardium, RV wall, then the RV cavity. So this dark space here represents the RV cavity, corresponding to right here. Then after the RV cavity, you have the ventricular septum. So this represents the ventricular septum, okay? And you can see that in systole and diastole. So in diastole, the ventricular septum moves out, in systole, the ventricular septum comes in, okay? Your ECG is on top, so echo is gated. That means, everything is either systole or diastole. All right, so below the ventricular septum, you have the left ventricular cavity. So this is your left ventricular cavity. And below the left ventricular cavity, you have the posterior wall. This corresponds to the posterior wall. Below the posterior wall, you have your pericardium. So the pericardium, it's a little bit brighter than the posterior wall, you can see it. So in systole, the septum and the posterior wall moves in. So just look at your ECG again. Systole is from the onset of the QRS to the end of the T wave. So in systole, the septum moves down to meet the posterior wall. In diastole, it moves apart. So you can see that. So if you were to do measurements, you can do systolic measurements and diastolic measurements using M mode. Okay? So in systole, the septum moves downwards and the posterior wall moves upward. They move towards each other. And if you just look at the normal function of the heart, that's what the heart does. In systole, the heart contracts, and diastole, it dilates. So that's your RV wall. RV cavity, it's your septum, LV cavity, and the posterior wall. And the reason why it's, it has the shape that it has is because in systole and diastole, the heart contracts and dilates, respectively. That's your pericardium. All right, so measurement. So this is another thing they always bring on your tests. We don't use, well, the AC does not, the American Society of Echo does not recommend you use M-mode to do measurements. It's a historical perspective, however, but they still ask it in all tests. So if you're measuring the septum, septal thickness is measured at the onset of the QRS complex. LV dimension in diastole is measured at the onset of the QRS. And then the posterior wall thickness, again, is measured at the onset of the QRS. Okay? And this is how it's done. Okay? Again, it's the American Society of Echo does not recommend that you do it. It's of historical importance. So they're going to bring it on your test. Septal measurement at the onset, so you have your ECG on top. At the onset of the QRS, you measure the thickness of the septum. You measure the LV cavity size. At the onset of the QRS, that's diastole. That's end diastole. That's the end of diastole. So you measure your LV cavity size and the posterior wall. So those are diastolic measurement. So in your LV dimension in systole, the recommendation is that at the lowest point of the septum, okay, the lowest point of the septum, you drop a perpendicular down to the posterior wall, and then that is the LV dimension in systole. And it should correspond to the end or close to the end of the T wave. All right. So you move a little bit beyond the mid cavity, and you move towards the mitral valve. So the cursor is crossing these structures. The transducer is on top. So basically the same thing. What are the structures that the transducer is looking at? It's looking at first the chest wall, the skin, subcutaneous tissue, the muscles, that sort of stuff. And then it gets to the pericardium, the RV wall, RV cavity, septum, LV cavity, and then the mitral valve. So similarly, with your M mode, you have your chest wall, RV cavity right there, your septum, LV cavity with the mitral valve in place. It sees the anterior mitral leaflet first. Okay, so the first portion of the mitral valve is the anterior leaflet, then the posterior leaflet. So this right here is the anterior leaflet of the mitral valve, and below is the posterior leaflet. The mitral valve opens in diastole. So if you look on your ECG on top, in diastole, it opens. And you have this sort of M configuration of the mitral valve. Okay, so you're going to have your M configuration of the mitral valve. Okay, so the anterior wall should have a M configuration, and the posterior wall should have a corresponding W configuration. Mitral valve opens in diastole, closes in systole. These different points on the mitral valve have a meaning, and you need to know the meaning. What does it mean? All right, so that's your anterior mitral leaflet. Posterior leaflet is below, and in systole, the leaflets meet together. So you have this sort of, straight line. So systole and diastole. So what are the different points in your mitral valve? So again, you have this M configuration of the anterior mitral leaflet, and the posterior leaflet should have a corresponding doubler to match that. So you have a D point, you have an E point, you have an F point, A point, and a C point. Okay, so basically you have this point right there, 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 and this. What does that? What the different points mean? So it's not difficult. All right, so the mitral valve opens in diastole, closing systole. So your D point represent end systole because this is the end of systole. The mitral valve opens in diastole, so the D point is end systole, the end of systole. Your E point is the early opening of the mitral valve. E point is the early opening of the mitral valve. And this E point septal separation should be less than 1 centimeters. The E point septal separation, we talked about it before we even did this lecture. The E point septal separation, it gives us an assessment of LV systolic function. LV systolic function. So this E point should be almost touching the septum, the early opening of the anterior mitral leaflet. It should be almost touching the septum. Normal value should be less than 1 centimeter. E point. The F point is the mid-diastolic closure of the mitral valve, mid-diastolic closure. And this is supposed to be relatively steep. Okay? This is supposed to be relatively steep. We call it the EF slope. Okay? So your F point is the mid-diastolic closure. And then the A point is due to atrial systole, atrial contraction. So when the atrium contracts, you get this A point in the anterior leaflet. And then the C point is closure of the mitral valve. So the mitral valve opens here, it closes. Because this represents in diastole, the mitral valve opens. This is the beginning of the opening. This is the end of when it closes. So this is, the D point is end systole, E point early opening, F point is mid-diastolic closure, A point is due to atrial contraction and atrial systole, and your C point is closure of the mitral valve. Okay? Now, if you go over, now we're over you can see we move from the mid-cavity level. We're over the mitral valve, now we're over the aortic valve. So these are standard positions. So we are over the aortic valve. So the cursor is across the aortic valve. Remember, the aortic valve is right there. So the structures that the transducer is looking at, the chest wall, of course. You'll see the pericardium, the RV wall. You see a portion of the RV. Then you get to the aorta, and then the aortic valve is inside the aorta. Then the left atrium, you have the left atrial wall. So these are the same structures that your M mode is going to see. The chest wall, pericardium, the RV wall, the RV cavity, and then this is the aorta. Okay, so this is the aortic wall, and then the aortic valve is inside the walls of the aorta. The aortic valve is inside there. Remember, the aortic valve opens in systole, closes in diastole. Opens in systole, closes in diastole. When the aortic valve opens, it has this rectangular shape. It has a rectangular shape when it opens. So it opens in systole in a rectangular fashion, and it closes in systole, you have the straight line. Your ECG is on top. Some places have it on the bottom. Remember, your echo is always gated, so you can determine what is systole, what is diastole. But you know, the aortic valve, this is the shape that the aortic valve normally takes, a box-like configuration or rectangular. And when it opens, it looks like the box or the rectangle. When it closes, as a straight line. So you know this is systole and this is diastole. Okay, then below this is the lower portion of the aortic wall. Below that you have the left atrium. Okay, so these are the standard structures. Again, when you're measuring the internal dimension in diastole, it is always measured at the onset of the QRS. So this is very important. Okay, again, the ACE, the American Society of Echo, do not recommend that you do M-mode measurements, but it's of historical importance, so you'll get asked this in exams. The internal dimension at the end of diastole is measured at the onset of the QRS. You measure the septal thickness, you measure the LV dimension in diastole and the posterior wall. When you're measuring the LV internal dimension in systole, you're going to get the maximal excursion of the septum downwards, and then you drop your perpendicular to the posterior wall, and that's systole. So septal thickness is measured at the end diastole at the onset of the QRS, as we showed before. The posterior wall thickness is measured at the end of diastole at the onset of QRS. We showed you that. Aortic root dimension is measured at the onset of the QRS. Okay, the aortic root dimension is measured at the onset of the QRS. Left atrial dimension is measured at end systole. That is where you have the largest distance between the posterior aortic wall and the posterior LA wall. So let's just go back. So again, septal thickness, onset. Okay, these are diastolic measurements. So they measure the septal thickness at the onset of QRS, LV dimension in diastole, onset of QRS, posterior wall at the onset of QRS. For your left ventricular dimension in systole, the lowest portion of the septum, you just drop your perpendicular to the posterior wall, and then that's your LV dimension in systole. Okay. So all your measurements are going to be at the onset of the QRS. All your measurements going to be at the onset of the QRS, except the left atrial. So the widest portion, which usually correspond to the end of the T wave of your left atrium, that's a left atrium measurement. The reason why your M-mode measurements are not very accurate is because a lot of time you're off axis. Okay, if you can ensure that your cursor is perpendicular to the structure you're measuring, then it's fairly accurate. But a lot of time it's off axis, it's oblique, and the measurements are not accurate. So that's why it's not recommended. So all your measurements gonna be at the onset of the QRS, especially except the left atrial dimension. Okay, all right. So how does aortic stenosis look on your M-mode? So with aortic stenosis, of course, the aortic valve is usually thickened and you have restricted opening. It's not opening well. So when you look at your M-mode, you have the usual structures. Your cursor is through these structures. You can see the aortic wall is a little bit thickened, but concentrate on the aortic valve. Okay, this is the aortic valve. You can see that the leaflets are thickened. So you have to know what a normal M mode across the aortic valve looks like. So you know that this is thickened. This aortic valve is thickened. Okay, aortic valve is thickened. This and so these leaflets are thickened. Okay, the aortic valve opens in systole, closing diastole. But you can see that the leaflets are thickened. Okay, and the opening excursion is reduced. So it's, you will have a hunch that the aortic valve is probably stenotic, and so when you do your two-dimensional. Another important point about the aortic valve is your bicuspid aortic valve. So again, your cursor is your two-dimensional echo is on top. The cursor passes these structures, and you can look. You can see the aortic wall, just the wall of the aorta. It looks thickened, but when you look at the aortic valve inside, you see it's a little bit thickened. You have to know what normal looks like. The insertion point, however, this the aortic valve is open. The aortic valve opens in systole and it closes in diastole. We call this insertion line. This insertion line should be at the midpoint in your the box. It should be midpoint. You see, this is off-centered. So when you see something like that, it usually tells you that you have an abnormal number of aortic valve leaflets. You're supposed to have 3 leaflets. So when it's abnormal, and the most common abnormality is a bicuspid aortic valve, this so-called closure line is off-centered. Okay? If you remember what your normal aortic valve looks like, it's supposed to be a very thin structure, box-like. This so-called insertion line should be midway at the where you have your box. It should be midpoint at this side, and it should be thin. Okay, you can see that this is a bit thickened. These leaflets are a bit thickened, and then the closure line is off-centered. Usually, when it's off-centered, suggests some congenital problems. Now we're going to look at patients who have severe aortic regurgitation. And just think about it. If you have severe aortic regurgitation, picture, in your mind's eye, use a parasternal long axis view. So picture your parasternal long axis view. You have torrential aortic insufficiency. That jet is going to impinge on the anterior mitral leaflet. And in diastole, that's when you're going to get your AI. In diastole, that's when your mitral valve opens. So that jet is going to impinge on the anterior mitral leaflet, and as a matter of fact, sometimes can close it. Well, not completely close it, but can restrict the opening, because both phenomenon occurs in diastole. And if you have torrential aortic insufficiency, aortic regurgitation, that jet can impinge on the anterior mitral leaflet. So in diastole, you'll get this so-called fluttering, and it looks like this, fluttering of the anterior mitral leaflet. So again, so remember the anterior leaflet is right there. It opens in diastole, closes in systole, opens in diastole. So you get this fluttering of the anterior mitral leaflet, and it looks just like that, fluttering. Okay, that's an indication of severe aortic insufficiency. They always bring that as well. Mitral valve prolapse. So mitral valve prolapse is very classic. Mitral valve prolapse, that is the mitral valve prolapse in systole. So it's a systolic phenomenon. Mitral valve prolapse is a systolic phenomenon. So everything is gated. Your ECG is on top. Okay, so you're looking across the mitral valve, chest wall, RV wall, RV cavity, septum, the mitral valve, the anterior leaflet, and the posterior leaflet. I mean, posterior leaflet is right there. In diastole, the mitral valve opens. In systole, the mitral valve closes. But in systole, the mitral valve bows downwards. Okay, so the systolic bowing of the mitral leaflet, okay, it moves downward. That is going into the left atrium. So if you see this on your M mode, it means mitral valve prolapse. Okay, the mitral valve prolapses into the left atrium in systole. All right. Mitral stenosis. So remember, so again, you have to have a clear picture of what your normal mitral valve looks like. With mitral valve stenosis, the mitral valve is just the opening is restricted. So your E to F slope is not going to be very steep. Okay, so again, your cursor crosses these structures, crosses the mitral valve, and you know the structure. This is your septum. But when you look at the mitral valve, so this is the mitral valve in diastole. The mitral valve is supposed to be so open in diastole. The anterior leaflet is right up here, the posterior leaflet. So you see there's not much opening, there's not much space, not much opening between the anterior leaflet and the posterior leaflet. And not only that, but you lose your E to F slope. The E to F slope is not as steep, okay? And you can see that the mitral valve is thickened. You can see it's thickened, okay? So you have to know what a normal valve look like, and then you can deduce, what is going on. All right, so patient with hypertrophic obstructive cardiomyopathy, of course, you can have different types. The most common type, of course, is a septal hypertrophy. So again, your cursor crosses the mitral valve, so you know the structures that the transducer is seeing. Your RV wall, RV cavity, the septum. So you can see, you can measure it. Remember, vertical axis is distance or dimension. So this is very thick. Your septum is very thick. The mitral valve is there. LV cavity. This is your posterior wall. Thick, very thick. So you can measure it. But let's look at the mitral valve. We know that the mitral valve opens in diastole. So we can see in diastole the mitral valve opens, which is fine. But in systole, you have an anterior displacement towards the septum. Okay? This is systolic anterior motion of the mitral valve. So again, you need to know what a normal M mode going through the mitral valve looks like. Okay, opening in diastole is fine, but in systole, we have this anterior motion of the mitral valve towards the septum. SAM. This is so-called SAM, systolic anterior motion. And these are classic. You always get them in the exam, but just sit down and work it out. Systolic, so it's systole, EKG is on the bottom. Systole is from the onset of the QRS to the end of the T wave. So in systole, the mitral valve moves up and touches the septum. Okay, SAM, systolic anterior motion of the mitral valve. Another common condition that you'll get is myxoma, left atrial myxoma. It's classic. Again, just look at the structures that your cursor crosses. Those are the structures that the ultrasound beam is going to look at. Okay, so again, you have your chest wall, RV cavity. This is the septum, and it look at the mitral valve. So it's your anterior mitral leaflet. It opens in diastole, closes in systole. You're not seeing much of the posterior leaflet, but you're seeing this material, this structure inside the mitral valve in diastole when the mitral valve opens. So what's happening is when the mitral valve opens, this mass tries to get out. It's trying to get out of the left atrium. So each time the mitral valve opens, it tries to get out. When the mitral valve closes, it goes back into the left atrium. Mitral valve open is trying to come out. So this is classic. You know, this is left atrial myxoma. They always bring this as well. Okay, so in diastole, you see the mass. In systole, you don't. Diastole, you see the mass. Systole, you don't, and diastole you see. So the mass tried to get out of the left atrium in diastole. All right. Also, fair game to get heart failure, systolic heart failure. Again, when the ejection fraction is reduced, your E point septal separation is going to be much greater than 1 centimeter. Remember, with your normal heart, the E point septal separation should be less than 1 centimeter. In a lot of scenarios, a lot of cases, the E point touches the septum. Okay? Remember, the E point is the early opening of the mitral valve. So you can see here, so in diastole, mitral valve opens, closing in systole, diastole mitral valve opens, closing systole opens. Okay, we have your E point, your F point, your A point, and little something is going on right there. You know, we have your D point right there, E point, F point, A point. You know, there's a little hump right there. Your C point is right here. This is our A point right there, and then the second hump is what we call the B bump. The B bump also suggests reduced ejection fraction, systolic heart failure, okay, and also your E point septal separation greater than 1 centimeter suggests a reduced ejection fraction, and your B bump. So this second bump there is what we call the B bump, okay, suggests reduced ejection fraction. Pulmonary hypertension, okay, which you're supposed, this is your so-called this is what the normal M mode across the pulmonary valve look like. So what we do, we didn't show you a case, a normal case of M mode across the pulmonary valve, but what you do, your short axis to the level of the aorta, you just put your cursor across the pulmonary valve, and you get, something looking like this. Okay, if this wave is very prominent, then it suggests pulmonary hypertension. Okay, so, and then we talk about a flying doubler. Okay, so you get the pattern across the pulmonary valve looks like this with pulmonary stenosis. So you can see that it looks like a doubler. Okay, so-called flying doubler suggests pulmonary stenosis. And then this wave is very prominent in patients with pulmonary hypertension. What about cardiac tamponade? So when you have patients with pericardial effusion, in addition to doing your two-dimensional stuff and your Doppler stuff, you should do a M mode across the you should do a M mode as well. So for tamponade, the definition for tamponade is diastolic collapse of the right atrium or right ventricle. with fluid, you don't have to have a lot of fluid for that to occur. Um, but when you and when you do your Doppler, so with tamponade, when you do your Doppler across the mitral valve, you get inspiratory decrease in your E wave. You get inspiratory decrease in your E wave by more than 25%. So those are the Doppler 2D features of tamponade. We'll go over that when we get to tamponade. But when you look at your M mode, okay, M mode is very helpful. So there's some fluid there. You put your cursor across the aortic valve and see these structures. Okay, so of course you have your chest wall. Below the chest wall, you're supposed to have the pericardium, then the RV wall, but you have this fluid. Remember, fluid is black. So you get this fluid right there. Then you get the RV wall. Below the RV wall, you have the RV cavity. Then you're going to see the aortic wall. The aortic valve is inside there. It opens in systole, closing diastole. Then below the aortic wall, you have your left atrium. If you look on your RV wall, you get in periodic indentation or collapse. You get in periodic indentation or collapse in the RV wall. Is this diastolic collapse? You can look at your EKG on top because you know what is diastole and what is systole looking at your ECG. But if your ECG is wavy, you're not sure what's going on, just look down here. Remember, the aortic valve opens in systole, it closes in diastole, it opens in systole, closing diastole, opens in systole, closing diastole. These indentation or these collapse are occurring in diastole because they occur after the aortic valve opens. So you can see you have diastolic collapse in the RV wall. So this is echotamponade. Okay? Echotamponade. So, in addition to doing your two-dimensional evaluation and your Doppler evaluation, you should do your M mode assessment to see if there is tamponade. Okay? So that concludes M mode. Again, if you know all those different M mode features, you'll do well in most exams. There are some additional stuff that you need to go over and look at.